Hello, and welcome to our webinar on Let's Take a Closer Look at Inpatient Rehabilitation Facility Documentation. My name is Jennifer Boniface, and I am one of the nurse analysts with the Provider Outreach and Education team. During today's webinar, we will look at some examples of documentation found in the Inpatient Rehabilitation Facility medical records. On this next slide, we have our disclaimer. It states that this education is for informational purposes only. Medicare rules change often, so please make sure you're looking at official CMS communications for the most up-to-date rules and regulations. These do take precedence over anything that is presented today. And as a reminder, CMS prohibits recording of this presentation for profit-making purposes. This presentation is being recorded by us and will be posted on the WPS GHA training page under Encore Presentations. On this next slide, you'll see a list of acronyms used during this presentation. During the presentation, if there are any acronyms that you are unfamiliar with, please refer back to this slide for guidance. Accurate and comprehensive documentation not only supports the patient's care, but also plays a critical role in compliance and reimbursement for inpatient rehabilitation facility stays. During today's webinar, to assist with understanding documentation requirements needed for IRF stays, we will briefly review required documentation for the inpatient rehabilitation facility stay, review examples of documentation, and answer provider questions as time permits. I'm going to begin with a quick review of the required documentation for the IRF stay. We discussed this information in depth in an earlier webinar on November 1st titled Documentation Requirements for the Inpatient Rehabilitation Facility. The encore for this webinar can be found on our training page. I've included a link for the encore presentation of documentation requirements for the Inpatient Rehabilitation Facility on the resources slide at the end of this presentation. For inpatient rehabilitation stays to be considered reasonable and necessary, the documentation upon admission to the IRF must show a reasonable expectation of the patient's need for complexity of nursing services, focusing on how the involvement of the rehabilitation nurse contributed to the overall needs of the patient's rehabilitative stay, close physician medical management, including the requirements for physician supervision and face-to-face visits, an interdisciplinary team approach for rehabilitation to allow for the development of a comprehensive plan of care and treatment tailored to the needs for each individual patient, intensity of services needed to demonstrate why the patient requires an intensive rehabilitation therapy program as opposed to therapy at a lower level of care, such as a skilled nursing facility or home care setting, and therapy service intensity with documentation showing the patient is receiving the required amount of therapy to meet the definition of intensive therapy. The reasonable expectation requirements can be found in the IOM 100-02 Medicare Benefit Policy Manual, Chapter 1, Section 110.2. A link to the Medicare Benefit Policy Manual, Chapter 1, has been added to this slide, as well as the resources slide at the end of the presentation. Per the Medicare Benefit Policy Manual, Chapter 1, Section 110.2, the documentation in the medical record must show a reasonable expectation at the time of admission that the following criteria were met. Requires active and ongoing therapeutic intervention of multiple therapy disciplines, requires intensive rehabilitation therapy program, is stable enough to meet the expectation to actively take part in and benefit from an intensive rehabilitation therapy program, requires rehabilitation physician supervision, and requires an intensive and coordinated interdisciplinary rehabilitation approach. Next, we'll review the documentation requirements for the inpatient rehabilitation facility. A list of document requirements for the IRF is listed on the next two slides. Documentation requirements include, but are not limited to, a pre-admission screening completed and/or updated within 48 hours of admission, an IRF admission order, an individualized overall plan of care completed within 4 days of admission and synthesized by the rehabilitation physician, documentation of the patient's need for intensive rehabilitation therapy services, completion of the Inpatient Rehabilitation Facility Patient Assessment Instrument, or IRF-PI, therapy evaluations and treatment records, interdisciplinary team conference records, physician orders and progress notes, nursing progress notes and assessments, social work and/or case management notes, acute care records, and advanced beneficiary notice of non-coverage ABM if applicable. So now that we've reviewed some basics, let's take a look at some different examples. I will go through each claim example and show you what was or wasn't submitted and the payment determination that was made as a result of the documentation submitted. Remember, since we can't actually see the patient in your inpatient rehabilitation facility, we must look at the documentation sent to help us paint a picture of the status of the patient. Therefore, it's crucial for you to send us all the necessary documentation to help us with reviewing the claim. Our first claim example is a paid claim. This patient had dates of service of May 13th, 2023 through May 26, 2023. This claim had all the IRF documentation requirements addressed, and therefore a determination for payment was made. We are going to take an in-depth look at each of the components of documentation used in reviewing this claim. We will scroll through the medical record, and I will highlight some of the key findings within the patient's chart. So on this first page, we can see that the pre-admission screening was completed on May 13th, 2023. This date meets the requirement of a pre-admission screening being completed and/or updated within 48 hours of admission. As you scroll down the page,
Jennifer?
Yes?
I'm sorry, your documentation's not showing.
Oh, okay. Sorry about that. Is it showing now?
Nope, I'm only seeing a gray screen.
Okay, let me see if I can switch that through. How about right now?
Yes, perfect.
Okay, sorry about that. Okay, so let me go backwards. You can see that the pre-admission screening was done on May 13th, 2023. So we're going to scroll down and take a look at the admission summary. So you can see that this patient was admitted from the acute hospital. The diagnosis was stroke, right body, left brain, or acute cerebral infarct involving the left anterior cerebral artery or cerebral infarct. The next page has the patient's acute hospital stay summary. The acute hospital stay summary mentions his comorbidities of hypertension, hyperlipidemia, coronary artery disease, and diabetes. We can see that he was admitted on 5/10/2023 after presenting with right lower extremity weakness. It also mentions that he has sleep apnea, but he is non-compliant with his therapy. Down here we can see that the patient's prior level of function and current level of function are listed in the summary to show the deterioration following the onset of the acute cerebral infarct. A set of pre-admission vital signs is also included on this page. All this information assists the IRF team with developing a full picture of the patient. The next few pages contain labs and a body assessment. So here we have our labs from May 11th and May 13th and an MRI results. And I'm going to go through this a little quickly. The respiratory status, our neurological status. You can see he's alert and oriented and has right hand dominance. Bowel and bladder, and you can see that he is continent. there is no skin alteration, so I'm going to go past that one. Eating and nutrition, and then his rehab needs. At the bottom of page 5, there is a chart with the patient's functional assessment. As we can see, the patient was independent prior to admission. He is currently at a moderate to max assist for most activities of daily living. And then the facility also included an expected level of function. And as we can see, he's independent with the exception of stairs, which is supervision to touch assist. Again, this information assists the inpatient rehabilitation facility team to develop an accurate picture of what the patient can and cannot do, and the goal of intensive rehabilitation program would be. The anticipated discharge plan after the IRF is listed on page 6. So the patient reports that he would like to go home following his IRF stay. On page 7, we have the patient's current plan of treatment of occupational therapy, physical therapy, and speech therapy. He reports the patient can tolerate 3 hours a day of therapy, which is a requirement for qualifying for an intensive rehabilitation program. His estimated length of stay is 21 days. And then we also have the anticipated services listed. And then the pre-admission screening is electronically signed, dated, and timed by the registered nurse assessors on May 12th and May 13th. Finally, at the top of page 8, the physician has documented the criteria for the IRF admission has been met and has summarized the basis for the admission decision. The pre-admission screening was then signed, dated, and timed electronically by the physician on May 13th, 2023. So next we're going to look at the admission order for the inpatient rehabilitation facility. The order was received on May 13th, and it was received as a telephone order, and we can see the physician electronically signed, dated, and timed the order on May 14th, 2023. Here's the first page of the history and physical. The history and physical was completed on May 14th, 2023, and it contains some of the same findings that were found on the pre-admission screening, including, scroll down to the functional assessment. So we can see it has the same information we saw on the pre-admission screening, and the discharge plan. Now, if you notice here under the discharge plan, the documentation states the patient plans to discharge home with his wife and the facility post-rehab program. However, later in the chart, the Inpatient Rehabilitation Facility Patient Assessment Instrument, or the IRF-PI, states that he's divorced. So we'll look at that documentation in a little bit on the IRF-PI. Now, if we scroll down to the bottom of the next page, we're going to find the additional social history. The documentation states that the patient lives alone in a one-story house and has supportive cousins in the area, and that he was visiting friends when the stroke happened. The documentation throughout the chart states the same information that can be found on this page. As you can see, there are some inconsistencies as to the patient's social history. It is important to remember that inconsistencies within the documentation could lead to denial of services. Even though this did not affect the outcome of this claim, if there are major differences, it could affect how the claim decision is determined. Under the free text A&P on the next page, we can see the patient was referred for a course of intensive inpatient rehabilitation. The physician documented additional information regarding the current functional status and expected improvement are in the pre-admission screening. The goals of each therapy are going to be provided are also documented on this page. So we can see PT is evaluating and treating for gross strength and mobility deficits, improved cardiopulmonary function, exercise endurance, range of motion activities, improvement of transfers, and DME evaluation. Occupational therapy is doing ADL training, strengthening, motor planning, and neuromuscular re-education. And speech therapy is performing cognitive speech, language, and swallowing evaluation. Finally, we're going to look at the estimated length of stay. The estimated length of stay is listed as 21 days. And then we can see both the resident rehabilitation physician, which is the information right here, and the supervising rehabilitation physician information here. They have put their attestations. And then they also signed, dated, and timed the H&P on May 14th, 2023. Next, we're going to review some of the physician notes. Here we have the first page of the physician note written on May 25th, 2023. The physician wrote a complete note for each day of the patient's stay. As I scroll through the notes, you can see that the physician wrote a complete assessment of the patient. Let's take a look. We have a review of systems, our subjective information, then our objective information, including vital signs and weight, a medication list, the functional progress, some lab results, and then he wrote the assessment and plan. Again, a free text A&P, which has some of the same information we saw in the H&P. And finally, we're going to go down to the rehab course. On the next few pages, sorry about that. On the next few pages, you're going to see some face-to-face notes that are written for the days of May 14th through May 25th, 2023. A separate face-to-face note was written by the physician each day and added to the previous day's face-to-face note. Each note had a summary of what was observed and any new orders or treatments. So here we have May 14th, then we have May 15th, May 16th and 17th, May 18th, May 19th, and I'm just going to scroll till we get to the 25th, May 20th, 21st, 22nd, 23rd, 24th, and then the 25th. As we can see on this next page, we have the resident rehabilitation physician and the supervising rehabilitation physician have written their attestations and then have electronically signed, dated, and timed the face-to-face note on May 25th, 2023. These next few pages are comprised of the patient's individualized plan of care. The patient's plan of care was completed on May 16th, 2023. This date meets the requirement of the plan of care being completed within 4 days of the date of admission. It was authored by the resident rehabilitation physician, and then this demonstrates the plan of care was synthesized by the rehabilitation physician, which is also a requirement of the IRF. Within the next few pages, you can see documentation of all the required components of the plan of care, including our expected discharge destination, which is home, our medical prognosis details and comments, the expected course of treatment, the intensity, frequency, and duration of each therapy. So we can see physical therapy had 60 minutes per day for 5 days a week for a duration of 10 days. Occupational therapy had 180 minutes a day for 5 days a week for 5 days. And speech therapy had 60 minutes a day for 5 days a week for a duration of 7 days. Here we have the functional outcomes, and they look like they're all going to be independent. And then our estimated length of stay of 21 days. We can see that the rehabilitation physician completed the attestation right here. And then both the rehabilitation physician, the resident, and the supervising rehabilitation physician electronically signed, dated, and timed the plan of care on May 16th, 2023. On this next page, I'm going to show you a snippet of the Inpatient Rehabilitation Patient Assessment Tool, or the IRF-PI. And I'm going to scroll down to line 10. We discussed this earlier, that the patient is listed as divorced. However, earlier in the presentation, we discussed inconsistencies on the discharge plan in the social history of the history and physical. where it said he was married. So I just wanted to show you that there is an inconsistency in the documentation. The next page has documentation of the patient's total number of minutes for week 1 and week 2 of physical therapy, occupational therapy, and speech therapy. The minutes reflect that the patient received only individualized treatment for each of the therapies provided. These numbers are consistent with the amount of therapy needed and the type of minutes needed for an intensive rehabilitation program. So we can see week 1, physical therapy had 353 individual therapy minutes. Occupational therapy had 450 individual therapy minutes. And speech language pathology had 360 individual therapy minutes. Then on week 2, we can see that physical therapy had 420 individual minutes. Occupational therapy had 435 individual minutes, and speech language pathology had 6 individual therapy minutes. The IRF-PI was electronically signed, dated, and timed by the individual completing the assessment. In this case, the certified rehabilitation registered nurse completed the assessment. We'll now look at the interdisciplinary team conference notes. Interdisciplinary team conferences were held on May 18th, 2023 and May 25th, 2023 for this patient. These meetings were held weekly per IRF requirements. Since both meeting notes use the same documentation format, we're going to only look at the interdisciplinary team note for May 18th. As we go through the documentation, we can see that there's a list of the meeting participants, as well as the documentation of the functional changes. Next, the team conference updates for each treating discipline are documented within the minutes. So here we have nursing, here's PT, and they are saying good progress. Occupational therapy, again, they have good progress. Speech language pathology, and they're also reporting good progress right down here. This is the case management social work update, and they are saying that he wants to return home. And then we have some other disciplines. We have our diabetic educator, because he is diabetic. And then the therapeutic recreation report is right here. The patient's discharge goal was documented that the patient wants to go home. And then discharge planning is found on the next page. So the estimated length of stay is 14 days. The anticipated discharge date is listed as May 26, 2023. The physician's attestation and concurrence can be found at the end of the interdisciplinary note, along with the electronic signature of the resident rehabilitation physician and supervising rehabilitation physician. Their signatures were also dated and timed. This last element I'm going to discuss for this claim is documentation to support the intensive rehabilitation program. These first 2 pages are the occupational therapy daily notes, as well as the signature page by the treating therapist. So we can see this is from May 14th, and it's the eval and daily note for OT. And then the signature log. And then we're coming to physical therapy, same thing. We have the PT eval and daily note for May 14th, and then a signature log. And as you can notice, the RN does sign on the signature logs for the therapists. Because here's our nursing note. And this nursing note is from May 13th. But again, they won't have the signature log after their notes because they do sign with the therapists. Finally, we have the speech language pathology or speech therapy note, which is the eval and daily note for May 22nd, 2023, and then their signature log. Treatment began within 36 hours from midnight on the day of admission for this patient. So these daily notes do support the patient's level of therapy that could only be provided by an intensive rehabilitation program. The initial evaluations for each treating discipline supported the information found on the pre-admission screening. And finally, the daily notes supported that the patient actively participated throughout his IRF stay. After review of the documentation sent by the inpatient rehabilitation facility, a determination was made to pay the claim. So I'm going to go back to the PowerPoint. Okay, so now that we've reviewed the documentation needed for a paid claim, we're going to move on to a denied claim. Example 2 is a denied claim with the dates of service of January 6, 2023 through January 15, 2023. For this claim, the documentation supported that the non-physician practitioner, in this case the nurse practitioner, performed more than one of the 3 required face-to-face visits starting week 2, whereas the physician only completed one of the face-to-face visits. I'm going to show you the regulations in the IOM 100-02 Medicare Benefit Policy Manual, Chapter 1 regarding face-to-face visits. You can find a link to that section on this slide as well as the resources slide at the end of the presentation. Per the IOM 100-02, Chapter 1, Section 110.2 on Sentence 4, the rehabilitation physician must conduct face-to-face visits with the patient at least 3 days a week throughout the patient's stay in the IRF. Beginning the second week of admission, the non-physician practitioner who's determined by the IRF to have special training and experience in inpatient rehabilitation may conduct one of the 3 required face-to-face visits with the patient each week. I have described 2 different scenarios used to determine the dates for week 1 and week 2. Scenario 1 uses dates from Sunday to Saturday when determining weeks. For scenario 1, week 1 would be January 6th through January 7th, and week 2 would be January 8th through January 14th. Week 3 would include January 15th. Scenario 2 uses dates of Monday to Sunday when determining weeks. For scenario 2, week 1 would be January 6th through January 8th, and week 2 would be January 9th through January 15th. The face-to-face notes in this claim were written by the nurse practitioner starting on January 9th. No matter which scenario we use, the IRF did not fulfill the requirements stated in the IOM 100-02, Chapter 1, Section 100.2. Please refer to this slide as a reference as we review the claim. So let's open the claim and take a look at the documentation. The physician completed the history and physical on January 7th. For the sake of time, I've only included the first and last page of the history and physical. The history and physical was sent with the medical record, did contain all the required components. The physician electronically signed, dated, and timed the history and physical on January 7, 2023. The documentation for the history and physical would fulfill the requirement for face-to-face visits for week 1 using scenario 1. The physician completed a face-to-face note on January 8th. Here's our face-to-face note on January 8th. The note contained a thorough description of the patient's status. So we do have our chief complaint, subjective information from the patient, our objective information with our history or with our assessment. And here's the medication list, vital signs, and then the assessment and plan. And you can see how he did all the information. He did treatments and plans for each of the diagnoses. And then he electronically signed, dated, and timed the note on January 8th, 2023. The documentation of the history and physical on January 7th and the face-to-face note by the physician on January 8th would fulfill that face-to-face visits for week 1 using scenario 2. However, January 9th through January 14th, the nurse practitioner completed all the face-to-face visits. The physician only completed one face-to-face visit on January 15th. No matter which scenario you use, whether you use scenario 1, so week 2 dates were January 8th through January 14th, or scenario 2, so week 2 dates were January 9th through January 15th, the nurse practitioner performed more than one of the 3 required face-to-face visits for week 2. So let's take a look at the nurse practitioner's daily notes. Again, for the sake of time, I've only included the first and last pages of the nurse practitioner's notes, as well as the discharge summary. Starting here, we can see that the nurse practitioner completed this note on January 9th, 2023. The nurse practitioner did complete all portions of the face-to-face note and then electronically signed, dated, and timed the note on January 9th, 2023. The physician also electronically co-signed the note on January 9th, 2023. On this next note, we can see the nurse practitioner completed the note and the face-to-face visit on January 10th, 2023. And then she electronically signed, dated, and timed the note on January 10th. Let's get down to that. And then the physician also co-signed this note on January 10th, 2023. Per this next note, the nurse practitioner completed the face-to-face visit on January 11th. And then co-signed or signed the note rather on January 11th, 2023, and the physician co-signed the note on January 12th, 2023. As we continue to scroll, we can see the nurse practitioner completed face-to-face visits on January 12th, 2023. And I apologize for scrolling through quickly. And then it was electronically signed on the 12th, and the physician signed on the 16th. Here's the note for January 13th. And then again, it was co-signed, or rather signed by the nurse practitioner on January 13th and co-signed by the physician on January 16th. And here's our note from January 14th. And again, electronically signed, dated and timed by the nurse practitioner on January 14th and co-signed by the physician on January 16th, 2023. Our discharge summary was completed on January 15th, 2023. The physician completed all portions of the discharge summary. And then electronically signed, dated, and timed the note on January 15th, 2023. The history and physical and the discharge summary were the only face-to-face visits performed by the physician in the documentation submitted by the IRF. In the case of this claim, the physician did not meet the face-to-face visit requirements found in the IOM 100-02, Chapter 1, Section 110.2 of conducting face-to-face visits with the patient at least 3 days a week throughout the patient's stay in the IRF, and therefore the claim was denied. So we're going to go back to our PowerPoint. The final claim example, example 3, is a partially paid claim with dates of service of December 20th, 2021 through September 15th, 2022. For this claim, the dates of service from December 20th, 2021 through January 13th, 2022 were paid. The dates of service of January 14th, 2022 through September 15th, 2022 were denied. The documentation showed the patient was awaiting placement to a long-term care facility starting January 13th, 2022, but continued to receive therapy until June 2022. At that time, the patient started to have a significant decline in status and was placed on comfort care until the end of her IRF stay. The claim was therefore denied starting January 14th, 2022, due to not supporting the medical necessity of the IRF stay and the intensive rehabilitation program. Upon admission to the IRF, the patient was determined to be appropriate for an intensive rehabilitation program and close physician monitoring. The documentation sent for this claim addressed all the technical components of documentation, so we will not be discussing them at this time, but rather focus on the documentation surrounding the medical necessity of the inpatient rehabilitation facility stay. We'll start by reviewing the documentation on the on the interdisciplinary team plan of care meeting notes. The documentation for the interdisciplinary team meeting on December 22nd, 2021 is on page 1 and 2. Interdisciplinary team conferences for this patient were held on a weekly basis per IRF requirements. On page 1, you can see that the medical diagnosis, or medical prognosis rather, is good, and the rehab prognosis is fair. On page 2, we can see that the estimated length of stay is 3 to 4 weeks with an estimated discharge date of January 13th, 2022, and a predicted discharge destination of skilled care. So now let's scroll down to the next interdisciplinary team note that was completed on January 11th, 2022. For this interdisciplinary team meeting, the estimated discharge date still remains as January 13th, 2022, and the predicted discharge destination continues to be skilled care. However, starting with the interdisciplinary team meeting note on January 18th, the estimated discharge date is documented as discharge pending accepting skilled nursing facility, and social worker continues to send referrals. The estimated discharge date changes again, starting with the interdisciplinary team meeting note on June 14th. Per this note, we can see there is no discharge date at this time, and patient was placed on comfort cares. The interdisciplinary team note on September 13th, 2022, get to that one, still continues to document that there is no discharge date at this time. The note further documents that discharge is not appropriate at this time, and the patient continues on comfort cares. So now we're going to look at the physician notes for documentation of the patient's status during the IRF stay. On January 12th, 2022, and let me just show you, here's the date, we can see that the patient and the plan states to continued inpatient rehabilitation with an estimated discharge date of January 13th to the skilled nursing facility. The physician note on January 13th, 2022, again, here we are, you can see right here, it's January 13th, states the plan for the patient is to continue inpatient rehabilitation with estimated discharge date of January 13th, 2022 to skilled nursing facility, possibly delayed by insurance. Next, we're going to scroll to the physician note for January 7th, or sorry, for June 7th. This physician note reports that the plan is to continue limited inpatient rehabilitation care as established with an estimated discharge date pending skilled nursing placement. The note also states that palliative care evaluated the patient on June 6, 2022. The patient's wishes per palliative care were not to return to acute care, transition to comfort care if sudden decline or change of medical status occurs, no artificial nutrition, a peaceful death, and do not resuscitate, do not intubate. Per the nurse practitioner's note on September 13th, 2022, the patient was on comfort cares, DNR, DNI, and palliative cares. At the bottom of this page, there is documentation that the patient is not alerting or opening eyes, and the patient continues on comfort cares. Per the physician note on September 14th, the physician states that the patient did not awaken. The patient continues on comfort cares, DNR, DNI, and palliative care. And per the discussion section, scroll down to there. It says that the patient had a significant decline over the last 24 to 48 hours and was less responsive. The discharge summary for the patient was then completed on September 15th, 2022. And I'm going to scroll down to the narrative note on the next page. Per the discharge summary, the patient was initially admitted for intensive rehabilitation therapies. However, she was slow to progress. The patient continued aggressive medical management until the spring of 2022. At that time, palliative approach was started for the patient. The patient began to become less responsive at the beginning of September, with eventually becoming unresponsive around September 12th. The discharge summary was then electronically signed, dated, and timed by the physician on September 18th, 2022. Finally, we're going to review the patient's therapy notes for this inpatient rehabilitation stay. The patient did not meet the intensive rehabilitation program requirements of either 3 hours a day for 5 days a week or 15 hours a week. Physical therapy, occupational therapy, and speech therapy notes were sent with the documentation received from the IRF for the claim. Per the speech therapy note on April 26, 2022, the patient was discharged from speech therapy on April 27, 2022, secondary to exhaustion of benefits and minimal progress. The recommendation made was to continue home program and continue speech-language therapy after discharge from acute rehabilitation. No further speech therapy notes were sent by the IRF after the April 26, 2022 note. So now we're going to scroll down to the occupational therapy note. Per the occupational therapy notes on April 25th, 2022 and April 29th, 2022, the OT plan of care had a frequency per minutes per day of PRN and a frequency of days per week of 1 to 3. So this one is for the 25th. And then the 29th note for OT has the same information. So we're going to scroll down to the physical therapy note now. Per the physical therapy note on May 3rd, 2022, the PT plan of care had a frequency of minutes per day of 30 minutes and a frequency of days per week as 3. The planned minutes per day and days per week of PT, when combined with the planned minutes per day and days per week for OT, would not qualify the patient for intensive therapy per IRF requirements. Just to show you that this is the note that was written by PT on May 3rd. And now I'm going to scroll down to the physical therapy note for June 2nd. Per the physical therapy note on June 2nd, both the frequency for minutes per day and the frequency of days per week decreased to PRN. To show you that it was signed June 2nd. Again, the planned minutes per day and days per week of PT, when combined with the planned minutes per day and days per week of OT, would not qualify the patient for intensive therapy per IRF requirements. After review of the documentation for this claim, the determination was made that the medical necessity for continued IRF stay was not supported after January 13, 2022. The claim was therefore denied starting January 14, 2022, due to not supporting the medical necessity of the IRF stay and the intensive rehabilitation program. I've included a link to the IOM 100-02, Chapter 1 for your reference. I've also included a link to the WPS-GHA website. Click the link on this slide and it will take you to the Encore presentations on the training page of our website. The Encore presentation of documentation requirements in the inpatient rehabilitation facility can be found under the recording date November 1st, 2023. Don't forget to click Provide Feedback link. Your feedback is important to us. It will help us with developing education to meet your needs. We are now at the end of the formal presentation. Please remember, if you have any questions, please put those questions in the chat feature and select Send to all panelists. So before we answer any questions in the chat, I want to go over a few pre-submitted questions. If we don't get to your questions today during the presentation, we will send out a document to all participants with the answers following this webinar. So question number 1 asks, if a patient is about to be admitted to the IRF and the physician has agreed with the pre-admission screening but hasn't signed it yet, can the rehabilitation physician let the rehabilitation nurse at the facility know he agreed with the admission decision and sign it when he visits the IRF next time he is there? The decision whether a patient meets the criteria for admission to the IRF must be made by the rehabilitation physician, since the admission decision requires a physician's determination. The rehabilitation physician should clearly document the review and concurrence with the findings and results of the pre-admission screening, then concur with the admission decision prior to the patient being admitted to the inpatient rehabilitation facility. This can be completed by the rehabilitation physician either physically or electronically signing and dating and timing the pre-admission screening, or by writing a separate statement documenting review of the findings and results of the pre-admission screening and concurrence with the admission decision. If the rehabilitation physician is unable to be present at the IRF to complete this, the physician may fax documentation to the inpatient rehabilitation facility. A verbal review and concurrence would not suffice and should not be accepted. And remember, this must be completed before the patient is admitted to the IRF. Question number 2 asked, what documentation is needed to substantiate the medical necessity of a continued inpatient rehabilitation? How should we document the patient's progress during their stay in the IRF? To substantiate the medical necessity of a continued inpatient rehabilitation, the patient's medical record needs to be comprehensive, clear, and supports the ongoing need for an intensive rehabilitation program. Some of the essential components of documentation required to demonstrate the medical necessity requirement include, but are not limited to, documentation on the patient's pre-admission screening of their medical condition, functional status, and rehabilitation needs, documentation supporting why care from a lower level of care, such as a skilled nursing facility or home health, is inadequate or inappropriate for the patient's clinical situation, documentation in the face-to-face visits and therapy notes of the patient's functional status throughout their stay in the inpatient rehabilitation facility, clear documentation of the patient's individualized rehabilitation goals, both short-term and long-term, and how these goals are related to the patient's medical condition and functional limitations, updates in the progress notes detailing the patient's progress toward their rehabilitation goals, interdisciplinary team conference notes at least once a week and as needed, demonstrating collaboration between the rehabilitation physician, the RN, social worker, and/or case manager, all trained therapists, and any other healthcare professionals involved in the plan of care with the patient, with updates given to by all healthcare professionals involved, and adjustments to the plan of care as needed to ensure that all the patient's care needs are met. And then our final question, pre-submitted question, question number 3, asks for examples why a borderline patient qualifies for IRF versus home health with PT or OT or a skilled nursing facility. The patient has this provider, has had some IRF denials and was trying to understand the denial rationale. The provider states that it isn't safe to send the patient either home with home health PT, in her opinion, and asked why they should try to rehab someone instead of sending them to the IRF. And a borderline patient may qualify for several different levels of care. This could include IRF, skilled nursing facility, outpatient rehabilitation therapy, and home health. Each different place of service has different qualifiers that must be met for the patient to be admitted. The IRF has the highest intensity level for rehabilitation services. This level of care is intended for patients who, due to the complexity of their nursing, medical management, and rehabilitation needs, require and can reasonably be expected to benefit from an inpatient stay and an interdisciplinary team approach to the delivery of rehabilitation care. They must be able to participate in intensive rehabilitation at the time of admission, which means up to 3 hours of therapy services a day and 5 days a week. Patients that cannot meet this requirement in 100-02, Chapter 1, Section 110 should be considered for a lesser level of care, such as a skilled nursing facility. If you have a patient that is borderline and you don't think they will meet the IRF requirements, then as a provider, you should consider a skilled nursing facility level of care, especially if you do not feel they are safe to be discharged home with home health. To qualify for a skilled nursing facility, the patient would need to have a 3-day qualifying stay in an acute hospital as an inpatient in order for Medicare to pay. If they didn't have a 3-day qualifying stay or meet the other requirements for the skilled nursing facility as outlined in 100-02, Chapter 8, Section 20, then you would have to work with the patient on possible nursing home placement with outpatient rehabilitation, but they would be private pay at the nursing facility with potential coverage for outpatient therapy under Part B. There's also comprehensive outpatient rehabilitation facilities that the patient who's discharged home could participate in as well. This is an option if the patient needs multidisciplinary rehabilitation at a single location in an outpatient setting. You can refer to the Benefit Policy Manual 100-02, Chapter 12 on this as well. Each of these level of cares have different requirements that must be met in order for the patient to qualify for them. It is advisable to work with the hospital's social services department about the patient's needs and resources available in their area. And we will put the links to these sections of the IOM 100-02 in the chat. Okay, so now we're going to answer some questions from the chat. Do we have any questions?
At this time, we do not have any questions that have come through the chat.
On behalf of myself, Rachel, Mary Sue, and Provider Outreach and Education Department and Medical Review, thank you for attending today's webinar on Let's Take a Closer Look at Inpatient Rehabilitation Facility Documentation. Remember, this presentation will be posted as an encore presentation on our training page on the WPS-GHA website. Don't forget to watch the November 1st encore presentation of documentation requirements in the inpatient rehabilitation facility for a deeper explanation of the coverage criteria and documentation requirements of the IRF. Remember to take our survey with the link provided. We look forward to your survey comments and hope you join us at future events. Have a great day. You may now disconnect.